Right, let's just jump straight into this, shall we? Welcome to today's Explainer, where we're going to unpack one of the most severe, intense, and frankly bizarre medical mysteries of the human brain. I want you to imagine, just for a second, experiencing a headache so intense that it strikes completely out of nowhere in a matter of seconds. It's usually locked right around just one eye, and it brings with it a whole host of really strange physical symptoms on that exact same side of your face. I know, it sounds a bit like science fiction, right? But it's actually a very real, very serious medical reality known as trigeminal automatic cephalagase.
Now, you might be wondering, just how common is this? Well, here's the crazy part. It is incredibly rare. We're talking about a syndrome that's thought to affect less than 0.1% of the entire global population. So, a tiny, tiny fraction. But for that fraction of a percent, the stakes literally couldn't be higher. The pain is just relentless. And really, understanding exactly what's short-circuiting inside the brain is the absolute only way to find these folks some relief.
So here's our game plan for this explainer. 1. The ultimate headache. 2. Decoding the mystery. 3. The 5 types of cephalgias. And 4. Finding the right treatment.
All right, let's dive into section 1, decoding the mystery. We need to break down the biology here.
Okay, I know. Trigeminal autonomic cephalalgia sounds like an absolute mouthful, doesn't it? It's super intimidating, but it actually tells us exactly what's happening in the body. Let's deconstruct it really quick. Trigeminal refers to the trigeminal nerve. That's a primary sensory nerve in your face, and it has 3 main branches, V1, V2, and V3. The pain follows the exact map of where this nerve sits. Next up, autonomic. This refers to the involuntary cranial features that come with the headache. Basically, things your body is doing automatically that you literally cannot control. And finally, cephalalgia. This one's easy. It just comes from the Greek word cephal for head and algia meaning aches or pains. So put all that together, it's a head pain disorder linked to your facial sensory nerve that triggers involuntary physical reactions. Boom! And here is how that whole sequence actually plays out, through something known as the trigeminal autonomic reflex. The current thinking is that when the trigeminal nerve is stimulated, it causes this massive cranial autonomic outflow. So think of it like this. A pain signal starts in the cranium, right? It travels to the nucleus of the trigeminal nerve. From there, it's sent all the way up to the higher brain centers, which is where you actually perceive that awful pain. But here is where things get wild. It's a rebound effect. The brain doesn't just go, ouch, that hurts. It fires a powerful signal right back down, triggering this massive reflex. That is exactly why the pain instantly turns into visible physical symptoms. There's also this vascular theory out there suggesting this reflex could partly be caused by neurogenic inflammation in the walls of the cavernous sinus.
So what does this actually look like on a person's face? Well, it's a bizarre, intense, dual system malfunction happening in real time. It's essentially 2 opposing nervous systems, just completely going haywire at the exact same moment. On one side, you've got massive parasympathetic activation. This causes things like severe lacrimation, which is just intense tearing of the eye, along with a runny nose, nasal congestion, and eyelid edema, or swelling. But at the exact same time, you'll get sympathetic inhibition. The sympathetic nerve fibers are being blocked. That causes ptosis, which is a visible drooping of the eye, and miosis, which is when your pupil constricts. It's absolutely astonishing that these 2 biological extremes are crashing into each other on just one single side of the face.
But what's actually flipping the switch on this whole reflex in the first place? Well, researchers point straight to the posterior region of the hypothalamus. And this is fascinating, right? Because the hypothalamus acts as the body's internal biological clock. And these particular headaches display some incredible timing. They often follow this relapsing-remitting course, they show distinct seasonal variations, and, this is the craziest part, they have a clockwise regularity for single attacks. You can quite literally set your watch by them. This heavily implies that the biological clock in our hypothalamus is the absolute origin point for the whole illness.
All right, moving into section 2, and really the core focus of our explainer today, the 5 types of cephalalgias. Let's map out this taxonomy. Okay, so here we have the absolute core of the whole thing, the 5 specific types. The medical field actually categorizes them on a sliding scale using 2 main variables, duration and frequency. Essentially, how long does the attack last and how many times a day is it hitting you? As we go through these, you're going to notice a pretty strict inverse relationship. Generally speaking, the shorter the duration of the pain, the higher the frequency of the attacks. Let's kick things off with the most common one and honestly, arguably the most infamous, cluster headaches. The pain here is so unimaginably severe that it has tragically earned the nickname the suicide headache. Unlike some of the other types we'll look at, cluster headaches are actually significantly more common in men, usually starting right between the ages of 20 and 50. When we zoom in on the exact traits of a cluster headache, we see it sits on the longer end of our duration scale. A single episode of that severe, one-sided eye pain lasts anywhere from 15 to 180 minutes. But in terms of frequency, it's relatively low compared to the others, usually striking maybe 1 to 8 times a day. And true to their name, they occur in clusters that can last for weeks or even months. But then you get this incredible period of remission where the patient is completely symptom-free for 1 to 2 years. Oh, and a quick side note, these attacks can actually be actively triggered by things like nitrates and alcohol, which is definitely something patients have to watch out for.
Now, watch how this whole demographic and timing script just flips when we look at paroxysmal hemicrania and hemicrania continua. Paroxysmal hemicrania, that one's actually more common in women, usually starting in their 20s. And following our matrix rule, the attacks are much shorter than cluster headaches, lasting only minutes, but they strike with a much higher frequency. Now contrast that with hemicrania continua. Just as the name implies, this is a continuous, constant unilateral headache. It is completely relentless. It lasts for days or just never stops, but usually it hovers at a moderate intensity rather than hitting that blinding peak of a cluster headache.
But listen, if we're talking about extreme frequency, we have to talk about the final 2 types, where the number of daily attacks can hit a staggering 200. Yeah, 200 times in a single day.
We are talking about Sankt and Suna. These are absolutely the rarest of all the trigeminal autonomic cephalgias. Now, Sankt stands for short-lasting unilateral neural G-form headache attacks with conjunctival injection and tearing. Suna is incredibly similar, just with slightly different autonomic symptoms. In both of these cases, the patient experiences this awful, stabbing, burning pain. The duration is incredibly brief, often lasting literally just seconds. But I mean, imagine enduring that blinding, visceral pain up to 200 times a day. It is just a relentless barrage on the human nervous system.
All right, Section 3, finding the right treatment. This is the key to the cure.
So you might be asking, why did we just spend all that time rigidly mapping out that specific taxonomy of duration and frequency? Because getting the exact type right is absolutely critical for finding the cure. But first, there's a crucial baseline step. Everyone, and I literally mean everyone, presenting with these syndromes requires a mandatory MRI. Before any targeted treatment even begins, doctors have got to look at the brain to assess for any other underlying pathology. They have to rule out tumors, vascular lesions, or any other secondary causes that might just be mimicking these exact symptoms.
But once cleared, the treatments are incredibly specific to the subtype, proving for sure that this is not a one-size-fits-all medical mystery. For cluster headaches, the immediate go-to is 100% oxygen, usually through a Hudson mask for 20 minutes, along with triptans and preventative stuff like verapamil. However, if you have paroxysmal hemicrania or hemicrania continua, you need something entirely different. You need indomethacin, which is a highly selective anti-inflammatory drug. Actually, these 2 types respond so completely to indomethacin that doctors practically use it as a diagnostic test. And here is where the strict diagnosis really matters. If you give oxygen or indomethacin to a patient with Sankt or Suna, it won't help them at all. For those incredibly frequent, seconds-long attacks, patients actually require lamotrigine, which is an anti-epileptic drug. A misdiagnosis here literally leaves the patient in total agony.
Which really leaves us with this incredibly fascinating question to ponder at the end of the day. When we look at how these different headaches respond to such specific chemicals and how they follow these incredibly strict, watch-like schedules based on the seasons and the time of day, does the ultimate key to unlocking chronic pain actually lie hidden right there within the biological clock of our hypothalamus? The human brain is just an absolute marvel, and conditions like trigeminal autonomic cephalgias remind us just how much of its deep, rhythmic wiring we still have yet to fully understand. Anyway, thank you so much for joining me on this explainer today. Keep questioning, keep learning, and I will catch you on the next one.